All right, everyone. Today we are going to talk about three very important primary immunodeficiencies, right, that specifically affect the B cells, and that's why they are call it up as the B cells disorders. And rather than throwing the random facts at you, I want to help you understand why each disease behaves the way it does. And once the logic is clear, you won't need to memorize the list, but the features will make the sense automatically. Okay, so the first disorder that we are looking up to, that is the X-linked Agammaglobulinemia, right, which is also known as the Bruton disease. And just by the name, you need to remember it out as a highlight that okay, there is something related to the B cells. Okay, and actually, this is one of the clearest examples of what happens when the B cells simply fail to mature. All right, and the root of the problem is the mutation, right? The mutation into the BTK gene, all right, and which is also one of the tyrosine kinase gene, all right, or we also known as, for example, the Bruton tyrosine kinase gene. Another thing that you need to keep into your mind that the enzyme or this specific gene, all right, is mainly responsible for the B cell maturation, all right. So let's say that okay, from the early precursors into the fully functioning B cells, right, which specific gene is required? This BTK gene is required. So if this BTK gene doesn't work, the B cells just stop developing in the bone marrow and they never reach the circulation, and that means no plasma cells and no antibodies, nothing else, right? Okay, so you have to remember out this fact. And also another fact that you need to remember about that is why it is to be called as the X-linked recessive and why it is more in the boys. So you need to remember out that the girl would need the two bad copies, right, or two defective copies. Okay, for example, the girls, they do have the XX, and the other ones for the boys, we do have the XY. So because this is the X-linked recessive, this is more and higher in the boys, because one X, if it got defective, all right, the chances to get this mutation gets higher. But the girls, okay, they do need two defective X, right? So that's why the chances are less in them. Okay, another thing that you need to cover it up that the infants, okay, usually appear completely normal at the birth. Okay, this is one of the, let's say, the clinical presentation, right? Okay, over here we have mentioned that we do got the maternal IgG, right, which is lower. So here there's a beautiful concept that you need to remember that why does the infants, right, appear completely normal at the birth? Because actually they are protected for the first few months, right? The infants are protected by the first few months by the maternal IgG that cross the placenta. And exactly when that the maternal IgG starts declining, okay, usually the duration that you need to remember that is 5 to 6 months, okay. After 5 to 6 months, when this maternal IgG starts declining, we actually suddenly see or observe what recurrent bacterial or the enteroviral infection. So this timing is very characteristic and gives you actually a strong diagnostic clue. And you also need to raise up one of the question that what kind of infections do those infects they get. Okay, so think of what antibodies normally fight. Okay, you need to remember about that. So let's say that antibodies, okay, normally fight encapsulated bacteria like the streptoneumia, right, or the hemophilus, right, influenza, Neisseria. They also get enteroviral infections because antibodies help neutralize the viruses in the blood and the gut, right? That's why they have mentioned the both the bacterial and the enteroviral infections over here. Another thing that you need to remember in the BTK or the Bruton's disease, that is the absence of the lymph nodes or the tonsils. Okay, and why it is being important that tonsils and the lymph nodes are full of actually B cells follicles. All right, they are fully made up of the B cells follicles. So if the B cells are missing, you see, if the B cells are defective, so definitely they will not develop completely, and that's why they either be absent or either be the scanty over here. And of course we can also say it in such a way that these structures never mature properly, and it is very a striking clinical observation. And one more crucial point that you need to remember out that these kids cannot receive live vaccines. That's why it's been written over here that the live vaccines are contraindicated. All right, so you have to remember our one key point that without antibodies a live vaccine can actually cause infection instead of the protection. This is one fact that you need to remember. Why they do not have the live vaccines? Because without the B cells or without the antibodies, a live vaccine can actually cause infection instead of the protection. All right. So that's all about the X-linked. So now let's shift from a condition where all the immunoglobulins are present to one of the where only selective or only one deficiency is being over there. So what is the selective IgA deficiency? That is actually the most common primary immunodeficiency in the world. And interestingly, most people with it don't have any symptoms at all. All right, you have to remember out that mostly the person, okay, may not have any symptoms at all. So you may diagnose it by accidentally when checking the antibody levels, okay, for some any unrelated reason, like, okay, and let's think logically about the IgA. First need to remember about that it is the primary antibody. Okay, this is one of the primary antibody defending all the mucosal surfaces, as I've already told you in the class. For example, IgA also protects your respiratory tract, your GI tract, okay, our tears or our saliva, right? So if IgA is low, the weak points will naturally be the mucosal surfaces, right? So you need to remember out all of that. Okay, another thing that you need to remember about that that any sort of the patients, okay, who get the recurrent sinusitis, recurrent chest infections, and the recurrent diarrhea, okay, may need to check out the antibody levels, and you need to confirm how is the IgA levels into them, right? So some patients also develop SLE condition into that, okay? Some patients, they also develop autoimmune disease like SLE, and that's because the IgA deficiency is actually associated with the immune dysregulation, all right? So that's why you see, okay, the first thing, can see airway and the GI infection, all right? Majority are asymptomatic, and autoimmune disease, one of the example you need to remember in a disease, that is the SLE, all right? And another thing that you need to touch up, that the IgA deficiency is actually associated with our immune dysregulation, which means that immune system becomes a bit more prone to attacking the self tissues, and that's a very important clinical scenario related to the blood transfusion, all right? So the patients with the IgA deficiency may develop what? Anti-IgA antibodies, right? Okay, and if they receive the blood containing IgA, they can get severe anaphylactic reaction, all right? Why is that? Because they do have the anti-IgA antibodies, all right? And that is why if they receive any of the blood which contains IgA, they can also get what? Anaphylaxis reaction. And usually, actually, this is a key point that mostly examiners, they love to ask. I repeat it once again, okay? Sometimes because IgA deficiency, right? IgA deficiency, it is associated with the immune dysregulation. What does immune dysregulation means? That now the immune system becomes a bit more prone to attacking self tissues, all right? And now just see that we are going to connect this concept with the clinical scenario, for example, of the blood transfusion. The patients with the IgA deficiency may develop anti-IgA antibodies, okay? And now let's say that if they are receiving the blood containing IgA, they can get a severe anaphylactic reaction, all right? I need to touch up that. And another interesting point is related to the laboratory testing. So because the celiac screening tests are often based on the IgA antibodies, these patients may get the false negative celiac testing, all right? Need to remember out that. And not only because they do not have the celiac disease, but simply because they don't make IgA, all right? So another point that they may cause the false negative celiac, all right? And of course, okay, the false positive serum pregnancy test also because of the IgA, all right? Need to touch up that one. And so mostly the points that you need to cover up, okay, that should be that if IgA is only missing, the mucosal tissues, they may get harm. There may be the autoimmune diseases like SLE, right? There will be the higher risk of the anaphylaxis, all right? And you need to also touch up that IgA may get slower, but the other immunoglobulins or the antibodies are the normal ones, all right? Okay, that is something that you need to remember in the selective IgA deficiencies. And let's now touch up with one of the disorders, right, with no antibodies, okay? And we have just touched up that, okay, the selective IgA deficiency. Now touch up the CVID, all right, the common variable immunodeficiency. What is that? Okay, this is one of the clinically important immunodeficiencies, okay? So unlike the Bruton disease, what happens in Bruton disease? B cells were absent, right? But in CYID, okay, we do actually have the B cells presence, okay? B cells are present here. The B cells are present here, okay? But the main thing that you need to remember about that they fail to differentiate into plasma cells. These B cells are present, but they fail, okay? The defect is present in the differentiation. B cells gets differentiated into the plasma cells. That is major clinical feature, okay, in the CYID. And so they exist in the bloodstream, but they are kind to stuck in an immature or dysfunctional state. Means that now B cells are actually present, but they cannot transform them or differentiate into the functional state. And that is why immunoglobulin levels are low and the antibody responses are poor. All right. And you also need to remember about that this usually appears in the adolescence or early adulthood, right? Okay, it may present in the childhood but usually diagnosed after puberty. So if examiner asks you that CYID, all right, in the CYID, when does actually it's been present or it may show up the symptoms. So you need to remember that it may present in the childhood, but usually they wanted to ask you the diagnosis, right? So you need to remember that is after the puberty, all right? And another thing that you need to touch up over here that is okay. Let me explain you the reason also. You see that why does it's usually diagnosed after the birth? Because the young children still have the strong T cells, right, at that time, and sometimes enough residual B cell activity to cope up with that any sort of the bacteria or the things. So as the immune system matures and demands the increase, the deficiency becomes more apparent. Usually during the childhood, because we also have the T cells, right? That is why anything that is coming to the child is being targeting or it's being actually handled by the T cells present of our immune system. But as long as we get adult, now the immune system also wants to get stronger. And once the immune system wants to get stronger, okay, they need more soldiers to fight up with them. And at that time, when we actually see and observe that the immune system is get weakened and we got the test, so we find out that the B cells are not actually differentiating into the plasma cells, all right? And need to remember about that because immunoglobulins, especially the IgG, are lows, right? The patients get recurrent sinopulmonary infections, as we have discussed before, the sinusitis, the pneumonia, the bronchitis, many other conditions as well. And actually, repeated infections over and over time lead to the bronchiectasis. All right, one of the key disease that you need to remember over here that is bronchi bronchiectasis because of the again and again and over the time infections, right? And this is what is bronchiectasis. This is actually permanent widening of the airways, all right? And also what you need to remember about that if patients may also have actually lymphadenopathy, okay, and this must be taken seriously. Some of the laboratory findings may typically shows, okay, now you see that, okay, the plasma levels are low, right? Why the plasma levels are low? Because B cells are not differentiating into them. Immunoglobulins are levels are also getting low, and due to that majorly so many dysfunctional or the other problems are also came into being, including the bronchiectasis and also actually lymphadenopathy. Lymphadenopathy. Yeah, lymphadenopathy. All of that have to be taken seriously in these patients, right? Okay. So once you understand actually the logic of what each immunoglobulin does and how does B cells mature, these conditions actually stop being a list to memorize, all right? And you can just simply have the predictable consequences to remember that what if something gets failed, what could be the clinical finding or the presentation, all right?